That was with a 95% detection rate, almost with a false positive of 2 to 3%, and with NIPD on the block showing 99% detection rate. What is the role of second trimester ultrasound in today's terms of aneuploidy detection? And this takes me to Rupan's lecture, actually. We did varicocele analysis almost for 20 years, and today to be told that we don't need to do ultrasound in patients with azoospermia. If you've got a clinical varicocele, it's there and it's not significant. So similarly with second trimester ultrasound, we've been doing it since the last 30 years. Is it going to become as extinct as Rupan pointed out with varicocele detection? And let's just have a look. So what's the role of second trimester ultrasound in the context of first trimester screening? So there are 4 potential roles, and one is that even though women subject themselves to first trimester screening, at times they chicken out. They don't ask or they insist that they don't want to do invasive testing and they want to do an integrated test that is either second trimester biochemistry or second trimester ultrasound. So they want to convince themselves more that they are in fact in the high risk category, and therefore that would be the first category of women. Very small percentage of them. Most of them would accede to your request that you've got a high risk and you need to do an invasive testing. The second group of patients, just like I said, are those with low risk, who have been shown to be low risk with the first trimester screening and don't need any invasive testing. The third very important group is multiple pregnancies, and as you know, biochemistry is just about to emerge for multiple pregnancies as a possibility of risk estimation, but not really that efficient and accurate. So twins, and in our country with the embryo sculptors, as I call the art people, we have a lot of twins on day-to-day basis to handle. And of course, that large group of population in India where yet first trimester screening is not available and they yet come for second trimester screening. The basis of this talk is from this one article, which I request you must all have in your mobile phones, is from January 2013, because it's a very, very useful article, as I'll just go on to show. Before you do second trimester screening, these are some images I put forward to show that what is important in each image from the point of aneuploidy screening. And one is, of course, here you must look at the cavum. The lateral ventricle should be measured only in the posterior aspect, where there is the quadrigeminal cistern here, just above this level. Cerebellum and the posterior cranial fossa, that's the quadrigeminal cistern. So that's where you measure the lateral ventricle. You must look for the presence of the cavum. When you're doing anomaly screening, don't forget to look at the sagittal view, because it gives us a lot of information on the facial profile, the nasal bone, this soft tissue here called the prenasal soft tissue, prefrontal soft tissue. And also, very interestingly, this is a very important view to look for the soft palate. And I'll just show you in a minute. This here is the soft palate here. So that's the hard palate here, and this is the soft palate. And if you don't see this component here, you can sometimes pick up a palatal defect which is isolated from the lip defect. So this is a very important view on the sagittal scanning. These are some views that I have put together apart from what you normally do in the second trimester conventional screening. Don't forget to look at the middle cerebral artery. Specifically in hydropic situations, you need to do the MCA Doppler. But sitting inside that circle of Willis here in the center is the optic nerve. Of course, it's very difficult to make a diagnosis of septo-optic dysplasia, but you can see that that tissue which sits in the circle of Willis is the optic nerve. Taking off from that sagittal view here is the axial view of the mouth here. And what you can see here is the alveolar sockets, the lip, and the palate, and that soft palate which I was talking to you about earlier appears at the posterior-most portion. You also look at the orbits. And that portion here is the uvula, or the posterior-most tip of the soft palate. And if you see the uvula, almost certainly there is no cleft palate. So I'm not going to go too much into that detail, but if you can see that small dot here, that is the uvula, and you can see it both in the sagittal and the axial section. And then you sweep through the abdomen to look at the bladder, the bowel, the liver, the kidneys, etc. And don't forget that you have to look at the heart very carefully, at least the four-chamber and the outflow tracts. So that's the pulmonary artery, aorta, bifurcation, and all the various components. In the spine, don't forget to look at this one view, because it gives you the idea of the skin covering and the intactness or completeness of the spine. Also, it tells you where the spinal cord ends. So that's the end of the spinal cord, L1, L2, because most babies, even with closed spina bifida, the spinal cord will end here, and there is tethering of the cord. So these are some unconventional views, and don't forget to look at the fetal hand and the fetal feet. Taking off from there, the method of looking at risk estimation for trisomy 21 in the 80s and 90s was the Benacerraf scoring, which was if you have more than 2 minor markers or 1 major marker, you offer invasive testing. And this, as we know today, is completely given up. We never follow this technique now, and we only follow the corrected or the risk estimation, which I spoke about in the first trimester, which is you take the prior risk, which is usually the maternal age, or if you have done a first trimester screening, that risk, the combined risk, and then multiply it by all the likelihood ratio of all the individual markers. So this is just, of course, the maternal age risk, which is about 1:250 at the age of 35. At about 40 years, of course, the risk is very high, and you have to offer invasive testing, because even if you have all the markers which are absent, you cannot correct a risk of 1:100, and we'll talk about that. And this is the complete list of soft tissue markers as is highlighted in the 2013 journal, with all the current estimated likelihood ratios, and this is very, very important to have in your pocket diary. And how do we estimate the risk? As I said earlier, you take the background risk, whether this is the maternal age risk or the first trimester risk, and multiply all the soft tissue marker risks that you have with that risk, and you get the new risk. So if you have no soft tissue marker, that means your scan is completely normal, your risk becomes half. So which was 1:200 becomes 1:400. So if your scan is normal, done by an individual who's very well trained in picking up soft tissue markers, your risk becomes half. And I will talk about how to pick up soft tissue markers. But if you've got a likelihood ratio, like you've got echogenic bowel, likelihood ratio 2, so your risk becomes double. So 1:200 becomes 1:100. And this is the calculator, again provided free of cost, just like the FMF software that is there on the net. This is the calculator that is available with the 2013 journal. You just put absent, 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 or present, whatever is present, and it will give you the final likelihood ratio. You multiply this by the maternal risk or the first trimester risk, and you get the new risk. So this calculator is provided free of cost in that 2000 journal article. And this is how it works. So if you have minor markers like choroid plexus, echogenic cardiac focus, pilectasis, femur, the risk likelihood ratio is less than 1. So if you have a woman who's 28 with a risk estimation of 1:600, these markers will not alter the risk, and her risk remains as 1:600. If you have echogenic bowel, the likelihood ratio is about 1.5. So 1:600 becomes 1:363. So just divide 600 by 1.65 or 1.5. And by far, the worst of offenders that we have are these 4. And you have to remember them. That's nuchal thickness, absent nasal bone, ventriculomegaly, and aberrant right subclavian artery. So look for these 4 markers very aggressively, because the likelihood ratio is 4. So you divide 600 by 4, it becomes 1:150. So it's very, very quick, very easy to do. But if you have multiple markers, you need to use the calculator, because then the likelihood ratios vary when the markers are multiple. So let's look at the minor markers as we see here. Now, since these markers are so important, it's important that you pick up the markers very correctly and don't label some normal variants as markers. So choroid plexus cysts have to be perfectly round, loosened. They may be of any size. They may be unilateral or bilateral, doesn't matter. It should not be like this here. You see here, this is some lucency that you see here. This is not perfectly round, and it's not a choroid plexus cyst. This is a normal variant we see many times. It's because of partial voluming. It's the CSF which is getting cut on the surface of the choroid plexus, which is irregular and therefore erroneously labeled as CP cyst. But remember, when you have choroid plexus cyst isolated, it is usually, again, just like the nasal bone, of no significance. It is usually not a marker for trisomy 21. It is not present in the calculator for trisomy 21 calculations. It is a marker for trisomy 18. So you automatically look at the hands and the feet and the single umbilical artery and cardiac examination. If all of that is normal, then almost certainly it's a normal fetus. But if you have a CP cyst, and if you've got talipus, or if you've got hand abnormalities, if you've got cardiac abnormalities, then almost certainly, if there is growth retardation also for that matter, then this is a case of trisomy 18. So it's not important from the point of 21, very important from the point of view of 18. Then echogenic bowel, very important marker, likelihood ratio almost 1.5 to 1.6. So it's important that we don't label any bright appearance of the bowel as echogenic bowel. And there is a perfect technique. So the echogenicity has to be brighter or as bright as the bone. And how do we test that? There is only one way of testing that. It's not the visual appearance of the bone and the bowel, which can be very subjective. But when you have a fetus with a bowel which appears echogenic, you touch the power gain, or you've got a power gain button, not the gain button, but the power button. Reduce the power so that you only see the bone, and if you're yet seeing the bowel as bright, then this is echogenic bowel. Know two things about this: only when you have confirmed that the bowel is echogenic by reducing the power, this is increasing your likelihood ratio by 1.5. But remember, there are a lot of differential diagnoses. You could be dealing with infections, so you need to have your torch titer. You could be dealing with just fetus swallowing blood. So if the mother had first trimester bleed, this could be a false positive. So you have to go into the history carefully before you label echogenic bowel. Pilectasis, as I said, again, it's not just the visualization of fluid. It is the measurement of the fluid, which has to be bilateral, has to be measured only in the actual scan, and it has to be between 5 and 10 millimeters. So anything above 5, between the 16 and 20 weeks, and if it is bilateral, it's pilectasis. Again, likelihood ratio is only 1. It's important if there are more markers, it will increase the likelihood ratio then. Looking at the echogenic cardiac focus, that's the echogenic cardiac focus. It's very important that it should be located on the chordae or chordae tendineae and should not be on the ventricular wall as you see here. If it is on the ventricular wall, this is not echogenic cardiac focus. So you have to see the location. It has to be on the chordae tendineae, and whether it is single, multiple, or in the left ventricle, it doesn't matter. It is then an echogenic cardiac focus. You have to rule out IUGR before you call a femur as small, or you have to see the parental size. If the parents are small, then do not call the femur small, specifically if all the bones are small, because this could be a racial variation. But in isolation, if you have the femur or the humerus which is small and the fetus is well sized, then this is a marker for aneuploidy detection. Moving on from the minor markers, we go on to the major markers, and this is really the crux of the issue. So you've got to measure your nuchal very carefully in the axial scan. It's just at the level of the cerebellum. You measure the maximum distance from the occipital bone to the nuchal, and it should measure more than 6 millimeters from 15 weeks onwards up to about 22 weeks. And the likelihood ratio individually is about 10, but if you combine it with other markers which are absent, then the likelihood ratio is 4. And as with the NT, it not only tells you that there is a high risk of aneuploidy, but also high risk of single gene defects and other genetic syndromes and cardiac abnormalities. And here you see an NT which is markedly thickened with choroid plexus cysts and other abnormalities. But there can be a lot of fallacies in measurement of NT. That's because sometimes the fetus keeps the neck hyperextended or flexed, as I told you earlier. And if you have a fetus which is hyperextended, or if your probe is angled in an oblique fashion, you may measure the NT, you may over measure the NT, and therefore technique is important. And we are looking at other markers which have the same significance of NT, and one important measurement is the prenasal thickness. So it corresponds to what you will be looking at the NT. Fortunately, this does not change with fetal position. So you measure this maximum thickness here, and It can indicate aneuploidy. As you can see here, this fetus has micrognathia and also prenasal thickening here. And normal being 2.4 at about 16 weeks to about 4.6 at 24 weeks. So absolute measurements, and it can indicate Down syndrome with a detection rate of about 70%. And here you see a fetus with trisomy 18 with talipes, there's hydrops, and there is increased prenasal thickness and micrognathia. Moving ahead from that, we have a combination of markers that one can use in addition to prenasal thickening or nasal or the nuchal thickening, and one of them is probably going to be one of the most important markers is the prefrontal space ratio, and this combines two markers. So as we talked about the facial angle in the first trimester, the facial angle increases because the maxilla is small in Down syndrome babies. So once the maxilla is small, we drop a line from the mandible across the maxilla in front of the face and measure the distance between this distance and the skin, and then you also measure the prefrontal soft tissue, combine them into a ratio. So if your prefrontal soft tissue increases and your maxilla decreases, this ratio will keep falling less than 1. Normally, the euploid fetuses, the ratio will be 1. That means this distance and this distance, that is D2 upon D1, is similar because the maxilla is normal in size. But if you have a ratio less than 0.2, then it indicates a higher chance of having Down syndrome with almost 80% detection. So it's performing better than the NT measurement alone. And you can see some cases of Downs here where the soft tissue is thickened and the maxilla is small. You almost don't have any space. The D2 is very small and D1 is big, so suggesting that the ratio is more than is less than 0.2. Moving on from nasal bone, from nuchal thickness, and all the allied measurements that you can do is, of course, our nasal bone. So that's the second marker, which is important. Technique I already spoke about, that's hypoplasia and absence. Again, it's not important in isolation. As you can see, in 5 to 10% of Asian population, this may be absent, and that was the question which was asked earlier. But if it is in a combination with other markers, you put it in the calculator, and it will give you a risk estimation with almost 70% detection rate, and overall the likelihood ratio is about 6.5. A very easy way of looking at nasal bone is compare the nasal bone to the BPD diameter, and nasal bone diameter is usually 1/10 the BPD diameter. So if your nasal bone is smaller or your BPD to nasal bone ratio is more than 10, this suggests that this is hypoplastic nasal bone. So you don't even have to refer to a chart, just measure it and look at the correlation. And you can see here a fetus with absent nasal bone here. Also seen, this was a twin pregnancy. One fetus had the presence of nasal bone. The second fetus had presence of nasal bone, which is not as bright as the skin covering. So that is considered as hypoplastic nasal bone. Another marker which is as useful as a combination of both the prefrontal soft tissue thickening and the nasal bone is combined together here. So you look at this measurement and combine it and measure and look at the nasal bone measurement, and you form a ratio. Normally the ratio will be, this is having a detection rate of almost 100%, and normally the prefrontal soft tissue is always 2/3 of the nasal bone. So this is less and the nasal bone is more, and the ratio is about 2/3. So if your prefrontal soft tissue increases and the nasal bone becomes small, a combination of these two markers, your ratio will increase more than 0.6, and the detection rate is almost 100%. So you have a fetus here with a small nasal bone, with a slightly thickened prefrontal soft tissue, and your ratio is 1.5. The prefrontal soft tissue ratio here was, of course, normal, suggesting that the maxilla is not hypoplastic. But here, because of the thickening of the soft tissue and the nasal bone, this fetus is at high risk of having Down syndrome. Although these are additional markers, it's not yet in the algorithm. In the algorithm, it is only nuchal thickness. This is just supposed to help you in your diagnosis. And the same fetus had hypoplastic middle phalanx, echogenic cardiac focus, and a small femur all together. So the third marker, along with nasal bone and nuchal thickness, is what is called as ARSA, or the aberrant right subclavian artery. It has a 30% risk of having Down syndrome, But the problem is it can be seen in 1% of normal population. So in 200 of us here, at least 2 of us will have an aberrant subclavian artery normally, and we will not even know about it. So that's the way to look at it. This is the 3-vessel trachea view. That's the pulmonary artery, aorta, and normally the subclavian artery goes in front of the trachea, that's here. If the subclavian artery is going behind the trachea is here. So normally it has a forward curve. If it has a backward curve, this is called as aberrant right subclavian artery. Again, this marker is not important in isolation. It can be normal if it's in isolation, but if it has other associated markers, you put it in the calculator and it has a likelihood ratio of 4. As you can see here, there is no forward curve. This is the subclavian artery which is going behind the trachea, and the same fetus had an AVSD, so of course it has a high incidence of trisomy 21. And then finally, mild ventriculomegaly, if it's between 10 and 15 millimeters, then that is a high risk for trisomy 21 or other aneuploidies. It's important that you don't do an oblique view measurement. As you see here, sometimes the near ventricle cannot be measured correctly. In that case, you never measure in an oblique fashion. You measure in the coronal fashion. You take a coronal view from the occipital area, and that's the best way of measuring the lateral ventricle, or you measure the distant ventricle in an actual way. And almost 30% of ventriculomegalies will be isolated, and you look for them, and these are the fetuses which will be on high risk. You rule out other causes of ventriculomegaly. You look at septae for infections, look for bleeds, look for holoprosencephaly, look for the lemon and bananas for spina bifida, and look for agenesis of the corpus callosum. This is not isolated mild ventriculomegaly. You have to rule out all these conditions, the Dandy-Walkers, the Dandy-Walker variants, the agenesis of the cavum septum, or the agenesis of the septum here, as you see in septo-optic dysplasia. And this is what I was talking about, the MCA here. You look at the MCA and you won't see the soft tissue here, which is the optic nerve. Or this is agenesis of corpus callosum. The coronal view is important, and if the ventricles are communicating, that is holoprosencephaly. So if you have isolated ventriculomegaly, again, same likelihood ratio, almost 10. So these are the major markers, and then I will rush through. The face, of course, is one of the most important things. You can have a depressed nasal bridge in some in skeletal dysplasias or aneuploidies. This is again thanatophoric dwarfism. There's micrognathia, there's cleft lip. So it's very important to look at the face, look at the ear. You can have preauricular tags, as you see here. You can have microortia, there's a small ear, and you can have alterations in morphology. For example, here the ear is reversed, and various other combinations. So the face is important, and then you look for major abnormalities. So the omphalocele, the esophageal atrasias, the cardiac defects, duodenal atrasias, these have a likelihood ratio of 25. So needless to say, in most conditions when you have a major defect, you will always offer karyotyping because the likelihood ratio is very high, as you can see here, even with an aortic override or an AVSD. A single umbilical artery by itself does not have an association with aneuploidy if all the other markers are negative. But if you have other markers, like you have a sandal gap here, or you have a small stomach, there's an aortic override with AVSD, then of course it becomes an important marker. Once you have your risk estimation from your calculator, then you offer amniocentesis or a fetal blood sampling, and that would be the correct way to go for second trimester aneuploidy detection. So second trimester, in conclusion, there is a definite role for second trimester estimation. Like I said, those 4 categories, you've got to integrate the various risk factors, look at the maternal age, look at the first trimester, if it is done, the combined risk, and then do the correct risk estimation before you offer invasive testing. We no longer use the Benacerraf scoring system. You've got to have that calculator downloaded on your computer. It has to be a non-directive counseling. You offer the risk to the parents, and they have to decide. And information should be given by individuals who are capable of doing invasive testing, or if you have facilities for doing invasive testing nearby. And the last important point is that if you have a normal scan and you are correcting the risk to a normal risk, you have a mother who's high maternal age, who's got a risk of 1 is to, say, 150, and you are doing a normal scan and correcting that risk to 1:300, that means you are telling her that you don't need invasive testing. You have to be very well qualified in your techniques to rule out all abnormalities, as I have shown you in the previous slides, all the markers. Only then do you tell the mother that you have no risk of having Down syndrome. And till then, you must use facilities of qualified people in the neighboring vicinity. I thank you very much for for inviting me here, and I hope I could stimulate some kind of interest in ultrasound in this audience, which is very infertility oriented. Thank you very much.